So the physio treatment of PPCS, so you're sort of looking, yes, you've got the categories that you had before, but you also then need to factor in anxiety, sleep disturbances, and general life pressures and stress also impacting all of those systems. And a lot of the education is then you need to centre that around what sort of things tend to be driving their symptoms. Like, is it purely, say, something physical, like when they get up from sitting down? Or is it things like their symptoms have flared after a conversation with their partner or their boss, because you have to treat those quite differently. And then I would also liaise with other people that are treating them so that lines of communication, both with the patient and about the patient, are consistent. So you need to have quite open communication with people so that then everyone's both giving them the same message, but then I would use strategies that, say, the psychologist has given them, or heart rate limits that the EP has given them, to try and actually then facilitate my areas of treatment as well. And I generally will use this analogy pretty early on with them, particularly ones that are struggling with the concept of pacing. So this would form part of my education around, instead of buckets of stress, I would usually use buckets of stimulation. And so things like, even if they're sitting in a meeting, even if they're not doing anything in the meeting, they're not presenting, they're not particularly having to listen, just being around people and noise and light might actually then be filling up their bucket. And unless they actually leave before the bucket's full, they'll be when they, before the bucket hits a particular level, that'll be when they start to actually hit certain symptoms. Usually I'll draw different sized buckets as well, because often their capacity at that stage, especially if they've had symptoms for, say, 18 months to 2 years, is a little bit lower. And so you might actually find that that's a good way of showing them that they do need to actually have more frequent breaks, but that it shouldn't actually be that way forever. And then drawing the next bucket across to sort of say that this can be what happens when you do have a break. Having a break might be just sitting still with your eyes closed and just trying to then empty your bucket, so de-stimulate a little bit before you then go and do something that starts to fill it again. And people really struggle with where, like, they don't want people sort of looking at them differently often. So if they don't have a particular office that they can go to anymore, particularly with, things like hot desking and stuff now, sometimes I'll just tell them to go to the bathroom and just sort of sit there for a minute, eyes closed, try not to look at their phone, because often they see things like looking at their phone or listening to a podcast as having a break. And at the moment, that's not really a de-stim break for them. So I would normalise the symptoms for them. So a lot of the times people feel that they've got, symptoms that might, especially initially if they haven't had sort of some good education before they've seen you, symptoms that might mimic either a more severe brain injury or some sort of tumour or lesion. And so trying to really normalise all of their symptoms as being regular for these post-concussive symptoms is a good thing. Often it's a lot of reassurance that they are aiming to improve and that we are still aiming for a full resolution of symptoms in this case. And then we've talked about the pacing education, trying to reintroduce in grade activity. Like, some people, it's still at those really chronic sort of 18-month phases, are not going outside particularly. So any sort of they'll develop a sensitivity to noise and light and people, so anything that's really unexpected they'll struggle with. So you might have to get them to go for a walk at, say, 8 o'clock at night so that they're not running into a whole lot of people, or at, say, midday where people are often at work and school. And just educating them on the different systems that can be actually impacted following a concussion, so the chart from before. But, yeah, the most important thing to reiterate to them is that we're still aiming for full symptom resolution and a return to all their normal activities, because often people then sort of make these pretty quick decisions on what they will and won't participate in, and it's really not the time to sort of do that. So I always say to them, particularly for, say, someone that says that they don't want to go back into AFL, for instance, I'll just sort of say that, my role is to get them back to the point where they're asymptomatic, and then they can make the choice as to what they do from a sport and exercise perspective. So exercise always forms part of the actual, both specific and just general exercise always form part of the treatment. So looking at cardio and weight training, particularly for the ones that are really neck-based, doing some upper back strengthening can really help. And with the weight training, starting off with single arm or single leg, so they don't need to necessarily do like a really big Valsalva for a double limb movement, can really help as well. So definitely wouldn't start with something like rowing because that's quite taxing. And I would start with things like a single leg press or a single arm cable row just to start them off. You're better off having a few sessions which aren't particularly exciting or particularly taxing on them from a fatigue or DOMS perspective, but having them be successful and feeling like they have actually managed to get out of it and not be particularly symptomatic, rather than having them feel like they've failed because they've only managed half your session